How can I remember all the measures of prophylaxis in end-stage liver disease? I agree with you. End-stage liver disease is very complicated and requires quite an extensive approach to keep these patients healthy. And preventive medicine is sometimes the best medicine for these cirrhotics with portal hypertension. So let me go through some of the issues you should consider for prophylaxis. I'll discuss viral hepatitis, spontaneous bacterial peritonitis, variceal bleeding, and common hospitalization issues. First of all, anybody with chronic liver disease should be immunized against hepatitis A virus and hepatitis B virus. So check these serologies, and if negative, you administer the Hep A vaccine at time 0 and 6 months, and the Hep B vaccine at time 0, 1, and 6 months. Secondly, spontaneous bacterial peritonitis. What is a given is that everybody should receive secondary prophylaxis. That is, if they've had a first episode of SBP, they warrant antibiotic treatment. What's not as clear is whether someone should receive primary prophylaxis for SBP. And at this hospital, our practice is now to initiate primary antibiotic prophylaxis if the patient is a child C cirrhotic and has a total protein in the ascites of less than 1.5. A total protein that's this low has very little opsonic potential, and bacteria are more likely to lead to infection. Third, variceal bleeding. What's clear is that any kind of prophylaxis is useless with absent or grade 1 varices. Once the patient develops grade 2 varices, which means that they continue to protrude into the esophageal lumen even after insufflation, these people need primary prophylaxis. What we know is that prophylaxis with non-selective beta blockade is equally as effective as using a protocol of variceal banding ligation. So your choice is one or the other, depending on the patient preference. If the patient has already had a bleed and we're talking about secondary prophylaxis, beta blockade plus banding is better than either one alone. Finally, how about some thoughts of the hospitalized cirrhotic patient? Well, we always deal with DVT prophylaxis in hospital. You may see an INR that's elevated in the liver patient, but don't be fooled into thinking that this patient is not at risk for forming DVTs. Remember, INR was developed for use with Coumadin or warfarin. It is not necessarily related to the liver patient with synthetic dysfunction. They are not producing protein C and protein S, for example, so they're just as hypercoagulable as they are hypocoagulable, and it actually balances out. These people need DVT prophylaxis. Good luck treating your patients.